Good morning. I'm Marcia Wilhite. I'm Chief of the Bureau of Water at Illinois EPA. And in response to public interest and recent press reports related to the possibility of pharmaceuticals in drinking water, the state of Illinois has been doing a small investigation looking at the presence of certain pharmaceuticals in drinking water, sampling at the raw water intake, and then also following the treatment process before it goes into the distribution system at City of Chicago, Aurora, Elgin, Rock Island, East St. Louis. Our purpose in looking at these five was first that Chicago is our highest population that's served by surface water. And the other surface water supplies that we chose were based on the proximity of their drinking water intakes at their surface water source, in this case all rivers, to wastewater discharge upstream. And we have this long list of pharmaceuticals that we are analyzing for in the samples. So just to summarize, we took 2 samples at each supply, and they're being analyzed for these substances. They're mainly common antibiotics, common antidepressants, anti-seizure, pain relievers, also indicators of human waste such as caffeine and metabolites and nicotine metabolites that are typical signatures of human waste. So I'm really glad that you've got the handout so that you don't have to copy down all these names. But I think about 60 or so substances, and these were chosen because this was these were the substances that were chosen in the USGS study that was done in the early part of the decade, looking at pharmaceuticals and personal care products in ambient water. Oh, we keep going. We are hoping to get the analytical results this week. And then our process is to not just provide the raw results to the public without any sort of interpretation, for them to figure out whether this is good, bad, indifferent, important or not, other than most people would conclude that if there's not detect, that would not be significant. So I'm going to turn it over to, I think I'm turning it over to Tom next, to describe the process that we expect to follow in evaluating the results. Nope. We'll get to him in a minute. We're going to talk about the other stuff. Another monitoring study that we're engaged in is to look for the presence of perfluorinated chemicals in ambient water. This kind of started with an interest situation that emerged in Illinois, in Minnesota, as they were seeing high concentrations of perfluorinated chemicals in ambient water and in fish tissue, and eventually traced the source to a couple of places, a 3M manufacturing facility that was manufacturing the substance, but then also they found that the chemical was being used in a product for in fairly common usage in industry, so it was showing up in some other places. So Illinois collaborated with other states along the upper Mississippi to do some sampling last season to look for the presence of perfluorinated chemicals, and we found some fairly high concentrations at the mouth of the Illinois and the mouth of the Rock River. So the sampling that we're going to do this year is going to look at concentrations further up into those basins. We actually have in Illinois a 3M manufacturing facility at Cordova, and so that is kind of a benchmark point for us in our sampling process. The 2007 results, I am told, were essentially kind of a range-finding thing to look at for the presence of the chemicals. I think we're doing a little bit more intensive look in 2008. Once we have those, we plan to put that together and report out the results. Okay, now I think it's Tom's turn.
What were those chemicals, fluorinated chemicals?
What were they? It's a class of chemicals, but I think that there's a perfluorooctanoic acid, I think, is an example. Also, there's perfluorinated octanoic sulfonate, I believe, are the two important ones.
As well as some others.
Yeah.
I think they're looking at a total of 12 or 16. I don't remember the exact number, but they're looking at more than just the two that are of biggest interest right now.
Yeah. And a challenge for, I think, all states looking at this is that there's not an ambient water quality standard for these chemicals. I think Minnesota has promulgated a fish tissue level for use in defining potential fish consumption advisories, and I think they've also defined a level of state MCL for drinking water.
And I'm Tom Hornshaw, a manager of the Toxicity Assessment Unit within Illinois EPA. And I'm going to talk a little bit about a couple of potential approaches that ourselves and the Department of Public Health may be able to use to at least give a first cut estimation of what may be, what is or is not a risky level of the various compounds that could be found and reported. We looked, when this program first started, I contacted Ken Runkle, Department of Public Health, my counterpart, about any thoughts we might have about coming up with the equivalent of a maximum contaminant level, MCL, for the various pharmaceuticals and personal care products that are being analyzed for. And there's a couple of ways that show some potential. And the first one would be just to use what is commonly prescribed for the various pharmaceuticals. Of course, that won't work for the other personal care products because they're not prescribed, but at least for those that have a milligram per day dosage, we can use that as for a lowest observable effect level, LOEL, for the side effects that quite often occur when drugs are prescribed. Assuming that there's a risk-benefit analysis that's done and the side effects are minimized at the same time that the beneficial effects are maximized. So we are assuming, going under the assumption that this is a lowest observable effect level for that particular drug. And then we'll add a range of uncertainty factors, UFs, based on what's in the database for each of these individual pharmaceuticals. And we'll use uncertainty factors of 1, 3, or 10 for, first of all, converting a lowest observable effect level to a no observable effect level, NOEL. That's pretty much already built in. Many cases, the drugs are given for short time durations, so there may not be a lot of chronic exposure data. So we will probably have to use an uncertainty factor to account for extrapolation from a short-term effect to a chronic exposure. Standard in developing any kind of risk-based evaluations is an uncertainty factor for the variability within the human population in their responses to various kinds of insults, and that's usually tenfold. In the cases where the drugs have been, the dosage has been determined primarily from animal experimentation, you may need to add an uncertainty factor for extrapolating from animals to humans. And then at the end of this process, we'll be converting what is the equivalent of a reference dose to equivalent of a maximum contaminant level, and that's a standard way of doing that, where you use the reference dose, which turned out to be wrong. It should be RFD instead of FRD, times the body weight to get the milligrams per day in the equation, and then divide that by the ingestion rate of water, IR, which is assumed to be 2 liters per day, and then use what is called a relative source contribution, RSC, that accounts for exposures to the chemical from all other sources of daily living other than drinking water. Typically, the US EPA will use a default of 20% if they don't have chemical-specific data. In this case, where the intent is, or the assumption is that people would only be exposed to these drugs when they're prescribed, the relative source contribution from other sources is probably going to be fairly small, so we may use something approaching 80% as a relative source contribution just from drinking water. Okay, which way do I go here? All right, I did it. And then the second potential approach, very similar to what I just described, same approach, same uncertainty factors, etc. But in this case, the database could be the maximum recommended therapeutic dose, MRTD, sometimes also called MRDD, maximum recommended daily dose, that has been developed by FDA. In this case, the database only contains studies only from humans, so you don't have to worry about extrapolation from animals. And it's also a fairly robust database with over 1,300 chemicals. Between the two of these approaches, we're fairly confident we can come up with at least a first cut approximation of what the acceptable level in drinking water could be. And then the last part of the approach will be to evaluate any additive effects with either of the approaches to account for chemicals that operate through the same mode of action or affect the same target organ. And then those effects will be separately evaluated to make sure that additive dose won't exceed an unacceptable level. And I think that's all we've got.